Well, good noontime to everybody. Welcome to Greater Washington's webinar, Only One Map, how transportation and health, racial inequities affect population health in DC. Could just apologize quickly if you're hearing a car alarm outside. It wasn't me, I didn't do anything. But welcome. We're really excited to offer this today. This is the culmination of some work we've been doing at Greater Washington, doing some research in this area. Through a generous grant from the Robert Wood Johnson Foundation. And also we're very pleased to welcome a couple of panelists today who I will now introduce. So the structure of today's webinar will be, we'll start off with some findings from our report on transportation health and racial inequities. We'll go into a panel discussion with Dr. Janet Phoenix, who's assistant research professor at GW's Milken School of Public Health, and Rachel Clark, policy director at the Redstone Global Prevention Center for Prevention and Wellness, also at GW's School of Public Health, Milken School of Public Health. Then we'll have some discussions, some opportunity for Q&A. I've got a few questions. I'm hoping I don't talk too long to get to my own questions, because I want to make sure to make some time for folks to raise any questions in the chat as well. So if you've got any questions, if you've got anything you want to probe into further, please put your questions into the Q&A, and our amazing staff, JC and Kate, will be collecting those, and we'll try and make sure that we get to the questions that are raised today. This webinar is recorded, so also be able to go back to it later on. So first, I just want to talk a little bit about the report that we were able to put together, just being finalized now. Is through some generous support from the Robert Wood Johnson Foundation. They had a grant for data to improve community conditions shaped by structural racism. And we also had some help from the Urban Institute in kind of we're new at doing health research in an institutional sense. So that was great to have that guidance as well. I'm very pleased to have these two panelists joining us today, who will then kind of discuss both their own work, and we'll probably try and bring in some of our findings as well. So what we looked at with this report was we had a district-wide evaluation of existing transportation conditions and health conditions on the ground, and really tried to kind of make those links clearer and closer together. We used a social and structural determinants of health lens for this analysis. Which I'll just touch on that briefly, because some folks might be more familiar with that concept than others. You know, it's the way WHO defines this is the conditions in the environments in which people are living, working, getting educated, they're experiencing their lives. It's through the built in the natural environments all around them. So it's, in many ways, this is sort of the unintentional way that we're creating health and population health outcomes. And it can create those health outcomes over generations and inequitably among different groups. And that's really why we're able to kind of look at transportation in that way and saying transportation does have these impacts for population groups. And we really wanted to kind of tease out the ways in which that's happening in DC. When I actually came to GWASH straight from the World Health Organization, working on social determinants of health. And my boss always used to say, people fall asleep by the time you get to the end of the phrase. But it's, you know, to me, it's a very profound kind of way of understanding why some groups have worse health outcomes and why that's reproduced in the long term. So I'll just get right into why how we're understanding these things. You know, you get this map here shows kind of multiple burdened communities. That's what these shadings kind of refer to. You have, these are all areas where all these things are, all of these transportation burden areas, people are having longer commutes, higher asthma incidence, lower household incomes, and there's also higher rates of traffic crashes. At the same time, you have lower income, you have higher proportions of people of color. So these are areas where you're having these kind of inequities playing out and are really, really concentrated. And we'll get into some more details about that in a moment. This is a really delightful map that we found from the Department of Energy and Environments. And I'll just take a moment on it, where it's kind of correlates death rates that are attributable to air pollution in DC. And you also see the percentages of the households that are Black households in each of these areas. And this is an incredibly strong correlation, and it's also terrifying. The idea that there's just these very, very strong, but to many people kind of invisible health risks happening, and that's happening on such a kind of closely related to racial identity kind of ways is highly problematic, and kind of really underscores why this is a public health equity emergency. Also want to get into rates of traffic violence. This is another big kind of area of public health, how people are experiencing injuries and deaths. This is an area that's near and dear to the heart of Greater Washington, as we're trying to kind of pursue this vision of the Washington region in which people can move around safely, they can experience their neighborhoods, their cities safely and enjoyably without the fear of violence coming their way, random and absolutely life-changing violence. And I think here you kind of it underscores, this is from an article actually published in GG Wash by Charlotte Lee last year, where it showed there's a strong correlation between these neighborhoods where many of the households do not own cars, and there's high degrees of crashes. Now, we're not trying to say that's like an exact this is because of that, a causal identity, but I think it underscores that equity element where you have wealthier, kind of more access to resources, households and individuals who are engaging in a behavior. I drive myself, I'm going to put my hand up, but it does create health risks for everybody else. And usually it's people outside of the car. So just wanted to kind of bring in that traffic violence element as well. Then jumping over to a related point, which is what we have high injury corridors and networks in the district. We have roads where people are a lot more likely to experience injuries, where again and again, DDOT will see that, be able to report on high risks of injury and death. And you have on the left, you've got I see it on the left, I actually don't know how you're seeing it, but you have one of these maps shows percentages, populations of Black or African American communities, and that you see is highly correlated with the high injury network corridors. And then the other map is showing those populations for Latino or Hispanic populations, and how that's also those communities are also where you're having a lot of these higher injury networks. There's lesser extents, there's differing extents, but I think that they tell a related story, which is that we're letting many roads in lower income and also neighborhoods with this high proportions of people of color, we're letting them be dangerous. We're letting them be like the river Styx, running through neighborhoods where people are living and working and going to school, trying to walk to school. We're really trying to we're letting them be dangerous places. And that has a very negative effect, not just on this generation, but on the next one as well. Here we're going to get into an area I know less about. I learned some of it during the report, but I know that our panelists will have something to say about this areas as well, is pollution. You've got multiple kinds of vehicle-based pollution. You've got PM 2.5, particulate matter, and you've got NO2, and those are both highly correlated both with cars, vehicle emissions, and with people's health outcomes. So, these maps, again, both show you've got these kind of some health outcomes are kind of turning up more in areas where there are higher areas of poverty. It is not always exact. It's not always like, where you kind of saying, oh, well, it's a perfect kind of lineup here. But you do see some interesting kind of trends, and we're going to talk about that more in the report, which we'll be publishing in the coming weeks. This should be my last slide, so you don't have to listen to me continue to talk, but we do have, I found this really interesting. We worked with a consultant, Lauren Hunt, on this report, and she just kind of came up with this toward the end, which was sort of highest and lowest transportation-related health burdens in DC. And she kind of came up with this points-based analysis, which, brings in, let me try and think, amount of pollution, definitely NO2 and PM 2.5. It brings in proximity to crashes and the number of crashes. It brings in asthma rates. And it looks at where are the places where all those things are kind of combined and creating a perfect storm of health burdens. And again, this gets us back to the title of this webinar, Only One Map. These are neighborhoods where we have higher proportions of people of color, we have higher proportions of people living in poverty. And it's, from an advocacy point of view, from a policy point of view, it's utterly unacceptable that we kind of let these burdens fall harder on certain communities, not just because of the equity argument and the generational argument, but because, they won't necessarily, like a higher burdened neighborhood won't necessarily have as many resources to dealing with it, dealing with health challenges. And that's really where we should be focusing a lot more, I believe, health policy resources. But as I love to soapbox, it's a fun thing for me to do. I'm going to thank everybody for listening to me talk about our work at GG Wash to begin with. And then I'm going to move it over to Dr. Janet Phoenix to take it from there and start our panel. Thank you, Dr. Phoenix.
Thank you, Caitlin, and really thanks to Greater Washington for doing this work and for creating this opportunity for people to hear about the work. I'm really appreciative of that. I have been talking, I think, in smaller circles for many, many years about the impact of transportation corridors on health in the District of Columbia. And a lot of that I've done because of an affiliation I have with Children's National. They have a clinic that provides services for children who have asthma in the District of Columbia. They see about 15,000 children in their patient population who have asthma. And many of those children, their asthma is poorly managed, and they're in and out of the emergency room often. And I run an asthma home visiting program for those children and have really been made aware of the connection between living along high traffic corridors and the possibility that your asthma will be poorly managed and land you either in the emergency room or the hospital. And so I'm going to talk a little bit about that today. Next slide, please. So, many of the neighborhoods that have exposure to traffic-related air pollutants are along the Anacostia River. And I like to start off by, it's a lovely river. But unfortunately, the river is really bounded by some of the worst traffic in the city. Next slide, please. And so you can see the Anacostia River kind of in the upper left corridor. You can see Benning Road, which is a high traffic corridor. And then to the right, the Anacostia Freeway, or 295, as it's often known, is, and so you have neighborhoods in the District of Columbia where you have lots of people who are have lower incomes than people living in the north and the west part of the city, and who are more likely to be African American or Hispanic, who are really living adjacent to these high traffic corridors. And it's a real issue. I happen to live on the Virginia side of the metropolitan area. I very often travel along the I-66 corridor when I'm coming in and out of the district. And I'm struck by the difference between that I-66 corridor, which has barriers along the sides that are 6 to 8 feet high, that really help to keep not only the noise, but also traffic-related air pollutants kind of in the traffic corridor and not in the neighborhoods to the side. And then when I drive along the Anacostia Freeway, what I see are chain link fences. And that freeway runs so closely to schools and workplaces. And senior citizen facilities, and it's just as well as very densely populated neighborhoods. And so it's a real contrast. It just seems as if the two jurisdictions have a very different framework in terms of the regard that they have for the air that people are breathing who live along those traffic corridors. And this today's talk really brings equity into the conversation. And if the transportation related corridors and the air pollution that goes along with that were the only concerns, then we might not be talking as much about equity. But you also have things like the Pepco Benning plant, which is pictured in this photograph, Most of the, what industrial facilities DC has, and we're not known for industry, those are also located in these neighborhoods that are heavily burdened by the transportation impact. So it really becomes an issue about equity, about the value that we place on low-income people and people of color in the District of Columbia, and why we continue to place facilities and traffic corridors in those neighborhoods. Next slide, please. So this is just a short list, and Caitlin touched on this, and there's probably a lot more information in the report that will be released soon about these pollutants and their impact on human health. I'm sure you are aware that these, when they're inhaled, can be very, very irritating to the lungs. And what I'll talk about a little bit later is the fact that people who are exposed to these traffic-related air pollutants can actually undergo genetic changes as a result of chronic exposure. And some of those genetic changes are inheritable. So what that really means is that this becomes an intergenerational issue. And so that the poor air quality that people are experiencing today can predispose their children and their children's children to develop diseases later in life. So this is really something that we're not only burdened with for this generation, but really we're creating conditions that are going to ensure that future generations are also harmed by these practices that we're implementing today. Next slide. I think I only have 2 or 3 minutes left. So as I mentioned in my introduction, I really work day to day on asthma. And I work with families to directly address some of the asthma triggers in their indoor environments, but there's not very much I can do to help them address environmental exposures in the outdoor environment. And many of those are related to traffic corridors like the Anacostia Freeway, the Southeast Freeway, New York Avenue. So we mentioned wards 5, 7, and 8, and those are the major traffic corridors that are running through those neighborhoods. And something, really has to be done. There's a movement across the country to reunite African-American communities of color that have been separated by these traffic corridors, because some of this was a deliberate plan in terms of city planning, that if we're going to put a highway somewhere, let's just put it right through an African-American community or a community of color. Let's divide the community. And there was very little concern about the impact of these traffic corridors. So there's a movement across the country to kind of reverse that practice and really begin to bring some of these traffic corridors down, to replace them with greenways, and to really pay attention to improving the environmental quality, especially for low-income communities of color. I mentioned the epigenetic impact of this. This just really cannot be dismissed, that if your grandparents live next to a highway, then you're more likely to develop respiratory disease. Next slide, please. I think I'm getting close to the end. So again, I work with young children like this child on a daily basis. There's no reason why this child should be in and out of the emergency room so often. It's a perfect storm in terms of living next to a highway and then also living in low-income rental housing that might be poorly maintained and has other issues such as mold and pest infestation. So everything combines to keep these children sick. Next slide. As I said, traffic related, there's such a huge, researched body of evidence supporting the links between exposure to traffic related air pollutants and health impacts. And it's not just respiratory disease. Other chronic diseases like diabetes are affected. And we're even beginning to recognize that there are effects on the developmental outcomes for children that can result from high levels of nitrates in the air and particulate matter. Next slide, please. So I'd like to close my remarks by pointing out this map that was generated by Children's National Because they are really the healthcare provider for most of the children in the District of Columbia who have asthma, they've been able to map out patterns that they've been seeing. And so the areas in orange and red are areas where they've seen the highest utilization. So, more kids going to the emergency room, more kids being hospitalized for their asthma. And the green area of the city is the area where those rates are lowest. And what is really striking about the differences, when you go from the red area to the green area, there's a difference of 23-fold. So 23 children in the red and orange areas end up in the emergency room or hospitalized for their asthma compared to one child who lives in the green zone. So I think I'll stop there. And I look forward to the discussion, and I look forward to hearing from my colleague at George Washington University.
Thank you very much, Dr. Phoenix. Some startling and really important findings there. I'm reminded a little bit, and I appreciate you showing, pictures of children. I'm reminded of a video I saw once of just brought out the sound of breathing of a child who'd lived near a polluted, in a neighborhood that was polluted by a near proximity to a freeway. And just when you listen to two different kids breathing, one who has had this exposure, one who hasn't, it just reminds us of the human cost of all the numbers and the colored maps that are helpful for us to understand. So I appreciate you kind of bringing that element. Well, thank you very much. And we've now got Rachel Clark here, also from GW, to speak further about the topics. I just want to ask everyone, please keep those questions coming. I see a couple of them in the chat. You can also use the Q&A function, and we'll collect those and bring those in a little bit later. Thank you, Rachel.
Thank you, and thanks so much for having me. As Caitlin said, I'm Rachel Clark. I'm the policy director at the Redstone Center for Prevention and Wellness, which is also at the Milken Institute School of Public Health, along with Dr. Phoenix. Our center works with community partners to support research and advance evidence-based policy solutions to address the interlinked public health threats of chronic disease and climate change. And so in DC, we focus a lot on promoting public health and sustainability through supporting sustainable food systems, equitable access to public spaces, and physical activity and active transport. So this topic is very central to my work. I'm going to go through some of the top health impacts that we try to highlight when we're thinking about transportation policy in DC. So I'll talk about air pollution, echoing some of what Dr. Phoenix brought up, noise pollution, traffic violence, also echoing what Caitlin introduced, and then also physical activity or inactivity and climate change. So just building on what's already been raised about air pollution, outdoor air pollution is one of the leading risk factors for disease and illness globally. It accounts for more than 1 in 9 deaths worldwide. And due to population density, cities have higher numbers of people exposed to traffic-related air pollution. Long-term exposure contributes to chronic diseases such as type 2 diabetes, heart disease, respiratory illness, and cancer. And we know in DC that based on recent studies that on-road vehicle emissions make the transportation sector the largest contributor to air pollution-related health burdens in the district. Over 50% of NO2 attributable asthma cases and 23% of air pollution attributable premature deaths. We also know from another recent study that air pollution exposure is unevenly and inequitably distributed in DC, that lower income residents and residents of color live in proximity to congested corridors. And as a result, particulate matter attributable morbidity and mortality are 5 times higher in the most impacted areas versus the lowest impacted areas. And actually, one of the authors of this study noted that most of the air pollution generated within the district comes from driving, and that we're likely seeing these results because most of the district's freeways pass through wards 5, 7, and 8. So another topic I wanted to raise is noise pollution, which is something I was not familiar with before I came to this work, but it is a major, studied health issue and actually one of the most common environmental exposures in the US. Over 100 million Americans have annual exposures to traffic noise high enough to be harmful to health. And a lot of research has found links between traffic-related noise exposure and heart disease, dementia, hypertension, and stroke. And these impacts can be severe. One study found that people living in noisier areas had a 30% higher risk of stroke and experienced more severe strokes. Despite the pretty strong research in this area, very few communities consider the health risk of noise in their policymaking. So that was something I wanted to highlight. As Caitlin introduced, another health impact of the transportation sector is traffic violence. Road traffic injuries are the leading cause of unintentional injury worldwide and a leading cause of disability-adjusted life expectancy. We often understandably think of traffic deaths and acute injuries when we think about traffic violence, but additional important effects are the disabling physical and mental health impacts of traffic injuries. They can reduce quality of life for decades, cause long-term missed work or forced early retirement, and often lead to or entrench poverty. And in DC, as has been noted in the previous presentations, we see that tracks with higher proportions of Black residents and residents of color have higher rates of fatal or serious crashes. Again, because they disproportionately reside near commuter highways, they pay the price for other road use in the form of injury, illness, and death. A topic that we think about a lot at the Redstone Center is physical activity, and I did want to raise how this is related to transportation policy and transportation decision-making. We see it as a secondary impact of traffic violence is that it also makes spaces feel unsafe for non-motorized users like pedestrians. So that leads to physical inactivity. Our reliance on cars has led to reductions in physical activity, which, as we all know, is important for the prevention and mitigation of diabetes and other chronic diseases. We have seen in the research that when we look at people who commute by car, when we compare people who commute by car to people who use active and public transportation, commuters who use active and public transportation have lower rates of diabetes and hypertension. We've also seen that long commute times contribute to decreases in physical activity and increased blood pressure. In the District of Columbia, according to the Health Equity Report, more than 1 in 4 DISC residents report no physical activity, which is notably higher than the national average. And like a lot of the other statistics that we've discussed today, this is inequitably distributed. So we see this most starkly when we compare rates of physical inactivity. In Ward 3, just 6% of people report no physical activity versus Ward 8, where 38% of adults report no physical activity. And of course, physical activity is a complex and multifactorial issue, but we know that the built environment plays a key role. And when the built environment prioritizes cars and creates unsafe spaces that are prone to traffic violence, this reduces the community's ability to safely walk, bike, recreate, or use public transit. And these physical inactivity rates align with neighborhoods that have longer commutes and more hostile built environments. We also know that high-income neighborhoods have more pedestrian and biking facilities, safety from traffic, and access to recreation than low-income communities. And then the last issue I wanted to note is climate change, which I think we're going to get into discussion later that links between transportation and health need to be emphasized more in the policymaking space, and the same could be said for the links between climate change and health. So as I'm sure everyone knows, transportation is a key driver of climate change and its health outcomes. In DC, it's the second largest contributor of greenhouse gas emissions, and of the transportation-related greenhouse gas emissions, 80% of those come from passenger vehicles. And climate change really is a health issue. It is already causing major health impacts across the world, and it's going to continue to do so. These include vector-borne disease, food and water-related outbreaks, and severe weather events. It also includes heat waves, which will exacerbate the issues we've seen with physical inactivity as it becomes more and more impossible to spend time outside, and wildfires, which will contribute to worsened air quality and exacerbate the effects that we're already seeing from traffic pollution. And as with all the other issues we are discussing, low-income communities and communities of color are most vulnerable to these health impacts. We know that climate change will not affect everyone equally, and individuals who are most vulnerable are those who are most sensitive to events like heat waves and who have less capacity to adapt and respond to the stresses caused by climate change. So in the Climate Ready DC plan, there's a vulnerable populations map that found that vulnerability to climate change is not evenly distributed across the district, and that Ward 7 and 8 are the most vulnerable. That's all I have for today, but I'm very happy to answer questions, and I look forward to the discussion. Thanks.
Thank you very much, Rachel. And I'm glad to see some questions already popping up in the chat and the Q&A that we'll get to in just a moment. I'm going to be a little bit selfish and start off with a couple of questions of my own. And I'll just start off saying, Dr. Phoenix, you've talked about environmental triggers of asthma in children, how this relates to air pollution. We know that there's multiple kinds of air pollution, right? There's the ambient air pollution, there's the indoor air pollution, which is not really transportation related, but the ambient definitely is. Could you just talk a little bit more how that relates to vehicles driving near historically underserved neighborhoods, how that picture has changed over time? And then also just thinking about the differences between ambient and indoor and whether that's playing a role in these inequities as well.
So I would have to say that there have been changes, certainly in the recent past, in terms of the volume of traffic in the District of Columbia. And that actually helped to underscore some of these patterns we're seeing in terms of disproportionate exposure to traffic-related air pollutants. So during the pandemic, when traffic really ground to a halt, we saw an improvement in air quality in these neighborhoods. And now, we're seeing a reversal of those trends, and we're going back to some of the pre-pandemic levels of traffic that we had seen in the past. And we have another colleague here at GW who I believe was involved in collecting some of the data that informed the study that you mentioned in your opening remarks, Caitlin, that kind of mapped some of the health impacts that were attributed to traffic-related air pollution in the district. So Susan Annenberg's work has helped to inform some of what we currently know, and they did look at that change, kind of that pre-pandemic through the pandemic and then post-pandemic period as they were doing their measurements. And they looked at satellite data, which was able to really give vivid images, particularly along the traffic corridors between Baltimore and DC, and they were able to see, where the levels of the pollutants were worst, and so it confirms kind of what your study is saying, and what we know about these relationships. I think that there's a little bit of an artificial barrier between kind of this indoor-outdoor ambient versus indoor, because particularly for people who are living in multifamily housing, it tends to be located close to traffic corridors. And the buildings are what we call leaky, which means that the pollutants that are on the outside of the buildings will eventually end up indoors, although there is, of course, an additional contribution from things like gas stoves that might exist inside housing units. So you get the combination of outdoor pollutants that are able to penetrate into the indoor space, and then the additional things in the indoor environment that help to make the area even dirtier, like environmental tobacco smoke and pollutants from gas stoves. So you get kind of an overlap. I hope that answers your question.
It does. That makes sense. And just want to create, Rachel, did you want to touch on that as well at all?
I don't think I have anything to add.
Great. Well, then in that case, I'll just move on to Rachel. Some of your wider work has related to how access to public space can determine health outcomes, sometimes in inequitable ways. And then you've talked today a lot about the public space as it relates to transportation. In fact, a lot of our public space in DC and many cities is actually roads, it's sidewalks, it's other spaces that people use to get from one place to another. Can you say a little bit more about how these dynamics play out in terms of equity in DC? Transit, bikes, cars, walking, do they change what public space means in different parts of the district?
Absolutely. So I said a tiny bit about this at the beginning, but the built environment and how we allocate public space plays a huge role in how space is used. So when and I think a lot of Greater Washington, event attendees are aware, when we prioritize cars in public space, that not only causes all these direct health effects that have been mentioned, pollution and traffic violence, it also has the secondary effect of making people feel like those spaces aren't intended for and aren't safe for non-motorized users or people, and the types of active transportation and use that we know are so good for our health. And so this affects how space is used and whether it's activated. You think about a car-free area like the wharf and how that's used versus a busy and dangerous commuter corridor, or Beach Drive in Rock Creek Park now that it's been closed to cars. Without cars, the streets become public spaces that allow people to gather and move around freely, let their children play. And incidentally, because they're places people want to be, businesses also do pretty well. I think another important aspect of this is how these spaces are how not only places we go to, but how we get from one place to another. And so streets and sidewalks are the way that we get to public spaces like parks and recreation facilities. We know that access to green space and recreation are very important for health as well, but many of those resources are only accessible by car. And even people who live even just a step away from Anacostia Park can't safely walk or bike to the park because it's surrounded by highways. And so the unfortunate fact is that when you designate a space for cars to move quickly, it can't be used by anyone else.
I think that's just right. Thank you. And, something we think about a lot at GGWASH is that, multimodal environments, places where people have multiple choices. And it's not just kind of restricting them to one, because you're automatically kind of rejecting or denying access to anybody who's not in that one kind of mode of travel. So we do have some great questions coming from the audience. I've got a couple more myself, but I'll switch over to participant questions. Just to start off with a housekeeping one. A couple of folks have asked if both of the panelists would be happy to share their slides. So just checking in if that's all right, if we can share your slides after the panel.
Sounds good.
Okay. Dr. Phoenix, are you happy for us to share your slides?
I'm going to have to get permission to share the map because it's a children's map. I just need to circle back to them to make sure that it's okay to share, but I can give you an answer tomorrow.
Perfect. Thank you so much. And we can always kind of work out if there's a version we can share, but I appreciate that. And sorry for the question on the spot. We had a few questions. I'm going to start off. We had a question about what data do you use to attribute a death to air pollution? Are there specific diseases we're looking for in people in the deceased? And if we looked at things like proximity to roadways, length of exposure to pollution, behaviors like smoking that are accounted for in the deceased, which are removed from the data. I can take a quick crack at this to begin with, and I'd welcome the panelists to speak as well. These are not always easy things to kind of pull apart. I actually noticed when this question came in where what I was talking about at the time, and that happened to be the DOE analysis when this came in that was looking at a variety of epidemiological data. I can put a great paper in the chat that I think talks a lot about these kind of attribution kind of challenges. In terms of specific diseases, I think there's a wide range that are associated with air pollution. You get heart disease, stroke, COPD, chronic obstructive pulmonary disease, acute lower respiratory infections, and then also cancer within the respiratory tract as well. So there's a kind of wide range of actual, causes of death. There's a few questions here around, proximity to the roadways, length of exposure to pollution. Those are very classic epidemiological questions. I'll let Dr. Phoenix maybe weigh in. And yeah, I think that's as much as I can kind of touch on that. Dr. Phoenix, would you care to weigh in?
Yes, and I wasn't involved in gathering the data for the DOEE study, but I would add diabetes to the list of chronic health conditions that are associated with air pollution. And I think it is challenging to do this work, to really try to tease out the impact of maybe a variable like smoking, for example, and how that could potentially cloud the picture that we're seeing. But I think enough work has been done in enough communities. Many of the communities in California, studies coming out of New York. I think we're at the stage now where the body of evidence is really robust enough that you can feel confident about the conclusions that are being drawn about these links between adverse health outcomes and air pollution.
And I'm not a researcher, so I don't think I'm going to improve upon those explanations, but I will put one of the studies I mentioned in the chat in case people want to, take a look at their methodology.
Great, thank you. Got a question about freeway removal projects, and I'm just going to kind of read this out. Successful freeway removal projects have taken place in a number of locations around the country. As DC looks seriously at how removing 695 could help knit communities back together, leverage better street design and tree canopy across these corridors, and thus help improve health and safety outcomes for all user modes. This sounds like a great GG Wash post, but it's, this is a serious and important question. And I'd have to say, not that I know of, as advocates, we were really hopeful there would be more opportunities in the Infrastructure Act that passed last year at the federal level to rethink the balance between freeways and other car infrastructure and transit, walking, biking. That only partially came to fruition. Transportation for America had some great analysis that was on a little bit of, well, there are a few opportunities here, but there's also a lot of missed opportunities. So a little bit of a mixed bag. I wanted to quickly bring in, the question reminded me of a story I noticed the other day, which is in Oregon, they've been fighting over a new freeway over a number of, years. And it's just died a death. The freeway, it kind of ended, Streets Blog had a story, it ended with a whimper, not a bang, due to lack of funds. It just kind of ran out of steam because of money. And it's kind of sad the whole case has been made against building this like new infrastructure that'd be bad for health, be bad for the environment. And in the end, whereupon that might have changed some hearts and minds, building new infrastructure can simply kind of fizzle out because it's incredibly expensive to build, especially in the US. It's much harder to fix this old bad stuff than to stop new bad stuff that has to kind of have the momentum of money behind it.
If I could add, Caitlin, I did, when I learned about this movement to bring, some of these highways down that are traditionally bifurcated communities of color, I folded it into some testimony that I gave before the City Council, the Transportation and Environment Committee, and I've never seen so many stunned faces as when I suggested that they actually take some of these freeways down, in light of the fact that they've made so many recent investments in adding new ramps and new connections to the freeways. I think they were really kind of stunned, but I thought I would set the bar high so that maybe we would end up somewhere in the middle. But I don't think serious consideration has been given to taking some of these freeways down. And really, in conversations that I've had with leadership in the Department of Transportation and also in the Department of Energy and Environment, and they collaborate about this issue of, the links between pollution, transportation-related pollution, and health. They just don't seem to have as rich an understanding as we do, perhaps, in the advocacy community about these links and the strong evidence base about the link. So it's a continuing conversation, I guess is what I would say. And I would encourage those who are attending the webinar today to join that conversation, because I think more pressure will need to be brought to bear.
I also know that there is DOT funding available specifically for this purpose, reconnecting communities that have been divided by transportation projects. And I don't know if DC is going for some of those funds or what corridors they're thinking about, but it is out there.
I think that's right. And I have heard of one study to that extent. I'm afraid I can't remember the freeway concern just at the moment, but there was grant that I think one grant that DDOT was going for looking at. Gonna get back to my list of questions here. Had interesting, we're sort of linking active transportation back to pollution. Is there a way to link air pollution and particulate matter exposure to urban cyclists, such as metrics taken at doctor's office or hospitals, bicyclists with respiratory issues or asthma? So I think this is asking about, if you are a cyclist and you're experiencing breathing in particulate matter, is there a health kind of risk there? Don't think I can bring in any perspective there. Other than to say the more cars we move off the roadways, the better the air will be for everybody, including cyclists and indeed drivers who are often breathing the same air. Let's see. So does the study break out the traffic violence incidents? How many included pedestrians? So this is the GGWASH study, I think. And does it address bus routes? So firstly say yes. The study does look at differential experience of deaths attributed to traffic violence for pedestrians versus other modes. I'm looking at a fun figure just now. The highest, equally high actually, wards for pedestrian deaths are in wards 8 and wards 2, and wards 8 and 2. 2 would, make sense from just the very, very high pedestrian kind of numbers in Ward 2. It's our kind of walkiest part of the city, for want of a more technical term. Ward 8, that is very troubling. That is very troubling to have the same, rate of pedestrian deaths there versus in our highest pedestrian part of town, because there are lower rates of foot traffic there. Ward 7 isn't far behind, and Ward 5 isn't far behind that. And then you have kind of some safer, kind of more. The safer areas for pedestrians tend to be wards 3, wards 1, and ward 6. Yeah. Let me just get to the next one. Does it address bus routes? It does. We love bus routes. So we do look at the number of both the bus routes that are available in underserved parts of town, how fast the buses are. Typically, they aren't as fast routes. They don't come as often. And those are things that do need to be addressed. WMATA does have a very timely project right now looking at how to improve the bus network, called the Better Bus Network Redesign, which is looking specifically at how to make the buses make trips faster, make them more reliable, make sure that there is great high quality service in underserved parts of the DC as a whole. So I think that there is some work ongoing with that. GGWASH has been engaged. We're part of the kind of community connections group. I've been encouraging people to provide feedback. I think right now you can provide feedback on the naming of the routes, which whereupon might sound a little tangential, is actually really important for how people access buses, whether they understand where the bus is going to take them, does matter. Yeah. So I'm going to get then to a question I don't have an answer to, but panelists might have heard something along those lines. Do the speakers, and for anybody who's late to the webinar, you will be getting a recording of the webinar afterwards. So don't worry if you missed the beginning. Do the speakers have any suggestions for great new tools for translating typical travel demand model outputs like VMT or increased emissions into the health impacts? I don't have a tool in mind. I do think, the public health world is fairly used to developing health impacts analysis from inputs of a variety of risk factors. So that might be a good kind of place to start there. I don't know if Dr. Phoenix, do you have any suggestions along those lines?
Yeah, I would say that I don't have specific technical expertise, to be able to provide a definitive answer to that question. But I agree, that this is something that, that needs to be explored in the district. I had an intern working with me over the summer who, just really wore herself out trying to understand some of the information on the DDOT site in terms of vehicle miles traveled and high traffic corridors and how they were measuring it. I mean, she must have sent just dozens of emails asking questions and never got a single response. And so she was able to get some insight from some of the folks who were working in Baltimore just to understand the terminology and, some of the metrics that were used. So I think that there's work to be done here.
Agreed. Thank you. And I just see that in the chat, this is why open chats are such a good thing in a webinar. Someone's provided a helpful resource, or a couple of them maybe, for looking at that kind of modeling approach. We have a question around local organizations that are involved leading advocacy for more equitable transportation. Thank you for that question. You've joined us here today at Greater Washington. We also have, there's a couple other fantastic organizations mentioned in the chat, Coalition for Smarter Growth, Washington Area Bicycle Association. I'd also just like to mention we have Transportation Equity Network, is a coalition of both direct service and advocacy organizations that are specifically focused on equity in transportation and reducing health disparities. And they're worth looking up. It's managed by my colleague Kai Hall at Greater Washington. It really includes a wide variety of groups that are all very engaged in this effort, and we'll continue to engage on the health side of these issues.
If I could add, there is an environmental justice coalition in the District of Columbia. It's a fairly new group, I think less than 2 years old. But one of the committees has been focusing on transportation equity as one of the concerns, and that that is part of a broader campaign that looks at health impacts like lead and asthma. And so the relationship between asthma and transportation corridors has been a focus. And so that group has been doing a lot of testimony for the city council, convenings. And so that's another resource in terms of groups that are focusing specifically on the equity impacts of transportation-related air pollution.
Thank you. Thanks, Dr. Phoenix. Wow, chat is active. Some great resources over in the chat there. I appreciate this. I'm going to try, I think we have time for a couple of more questions. I'm going to try to get to them. One from that in the Q&A that I think Rachel, you've taken a crack at answering. I just want to give some room to talk about this a little bit. Often reference to transportation does not explicitly include or give sufficient weight to pedestrian transportation, or walking or wheelchair users. If data collection on pedestrian non-commute travel were accurately counted, pedestrian travel would represent the majority of travel. And I think that's a really, really excellent point, is that we are all pedestrians at some stage, and that includes walking and wheelchairs as far as I'm concerned. Nobody's getting directly bouncing out of their house into a car or a bus or a bike or a scooter, unless you're my daughter. Then you're on your scooter right away. So, bearing that kind of perspective in mind, making environments work for pedestrians, I do completely agree is central. It's central for everybody. It's central for everyone's health. It's central for everyone's safety. It's central for our recovery efforts. And as the commenters noting to older adults and their safety and their ability to kind of navigate their neighborhoods. So just wanted to bring a little oxygen to that point, because I think it's a great one. And Rachel's provided an answer in the Q&A as well. We've got a great question also from the chat. What promising approaches do you see DMV transportation agencies pursuing to integrate these various perspectives, public health, climate change, equity, et cetera, as they prioritize projects or plan more comprehensive initiatives? I'll just share a thought and make some room for the panelists, is that this is classically one of the hardest things in public policy, is to get multiple sectors working together. My view is that this should be as much the health department's purview as the Department of Transportation's purview. It's not about abstract ideas of mode shift is I love it, but it's not, it's a very abstract idea, right? It's about whether or not people can safely, efficiently get around their city, and whether they're healthy doing that, whether they have options that they value. So I think, getting that kind of multi-sectoral working together, especially when it comes to Vision Zero, would be great. We have had kind of a limited degree of that in the district recently. But I do think, there's a lot of promising things like, bringing, expanding on the capital bike share program, for example, has real possibility for addressing both the equity and the kind of wider transportation and health issues. Would the panelists like to refer to that at all?
Sure. I'd like to add to what Caitlin said, that it would be great if we get the Department of Health more involved in DC's Vision Zero work. And one model of where this has been done successfully was in San Francisco, where the health department partnered with their transportation agency to develop their high injury network. So in DC, and I guess in San Francisco before, the high injury network was based on MPD data, which can miss important metrics, for example, unreported crashes and crashes where the injury appears later. And in San Francisco, they mapped hospital data alongside their police department data, and they use that to identify unreported injuries and update the severity of reported injuries. And so that provided a more accurate picture of the problem and where they should be focusing their resources and solutions. And it's my understanding that DC Health was actually exploring something similar, but I don't know the current status of that. I think another way, I completely agree with interagency collaboration on this, but another way of bringing health into the conversation is in messaging and getting people from the healthcare sector and the public health sector to provide input on these issues. And I think one really powerful example of this was earlier this year when the Committee on Transportation and Environment had a hearing on traffic safety, and they invited doctors from GW Hospital's trauma center to talk about what it's like to treat victims of traffic violence, and also to talk about how much they're seeing that, the volume, and the percentage of the injuries they're seeing that are coming from traffic violence. And so bringing that into the conversation in a more intentional way.
Just to add a comment about the interagency collaboration and coordination with regard to air pollution. I've been struck by the fact that a lot of the conversations occur in the context of planning. So, discussions about kind of what's going to happen in the District of Columbia over the next 5 to 10 years to 20 years. A lot of that takes place in the context of planning and zoning. And those discussions are interesting because they have such a long time horizon that very often the short-term impacts are not factored in. I remember being in one discussion looking at the New York Avenue corridor, for example, visioning around that. And they were saying, well, eventually there'll be more electric cars, running along New York Avenue, so we won't need to worry as much about traffic-related air pollution. Well, yes, that's going to happen, but it's, 15 years, 20 years down the road before the balance shifts between gasoline-fired vehicles and electric vehicles. And so what happens, in that 10 to 15-year interim time frame? And think about the impact that that's going to have, not only on the people, who are here today, but also on their offspring, because again, these impacts can be intergenerational. So entities like the Office of Planning, but also entities like the Metropolitan Washington Council of Governments, I think, need to get involved because some of these discussions really are regional in nature. They're not limited to the District of Columbia's government. These are decisions that are being made at tables where more than one jurisdiction is represented.
That's right. Thank you so much, Dr. Phoenix. And I appreciate that point in electric vehicles, because there's a question in the chat about this and how it, whether it's actually causes, what I've read is several sources, you actually get more particulate matter coming out of tires and brakes than you do from tailpipes. So even as we get EVs online, still going to have these air pollution issues if we continue our reliance on cars. I want to thank our panelists so much. This has been such a fascinating conversation for me. Dr. Janet Phoenix, assistant research professor at GW's Milken School of Public Health, and then Rachel Clark, Policy Director, Redstone Global Center for Prevention and Wellness. I want to thank our participants. I've really appreciated the questions and the comments we've had coming through in the chat. We'll be sending out a recording and all the slides we can kind of get together for folks to take part in, and just appreciate everyone again. Thank you so much for joining us.